The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to today's Tennessee HFMA webinar on solving the problem of uncompensated care. My name is Katie Tarr. I'm with LBMC in Nashville, Tennessee with our healthcare valuation services, and I'll be the host for today along with Jim, John, and Lindsay, who will be our speakers today. Just a few reminders before we start. We have posted the slides on our website, and they're also in the handout section down below. So you can click on the handout, or you can click on the link in the chat box to download the slides. You must be connected to the webinar for at least 90% of the duration of the webinar to receive CPE credit, and you must respond to at least 2 of our 3 polling questions today. I will also just give you a brief overview of upcoming Tennessee HFMA events. First, our next webinar for next month will be on August 11th, and that will be titled The Intersection of Valuation and Physician Productivity, and that will be presented by Elliot Davis DeCosimo. And you can go to tnhfma.org/webinars for more information. You can also save the date for our Fall Institute. It will be held October 21st through the 23rd in beautiful Gatlinburg, Tennessee, as usual, and more information will be coming on that shortly. Again, just a reminder, you have to be connected to the webinar for 90% of the duration of the webinar and answer at least 2 of the 3 polling questions to receive CPE credit today. I'm now going to give you a brief introduction to our speakers. We have John Walling, a 2007 graduate at the University of the South, who started his healthcare career with Bernard Health, and his goal is to advance Bernard's mission to be the world's most trusted advisor when it comes to helping people plan for their healthcare. Jim is a graduate of the University of Tennessee, Knoxville. He has a broad spectrum of experience in both the financial and healthcare sectors, most recently serving as a CEO of Stellar Care, a home health provider in Memphis. He also serves on the board of governors of St. Jude's Children's Research Hospital. Lindsay Van Cleve also graduated from Southern Methodist University, and she worked in insurance before moving to Bernard Health. She helps hospitals reduce uncompensated care by connecting patients with new coverage options and is currently working on a Master's of Healthcare Informatics at Lipscomb University. Please join me in welcoming our speakers today. Thank you, John, Jim, and Lindsay, for joining us.
Thank you all for having us. We're excited to be hosting the webinar. And so, Katie, thank you for the introduction. As Katie mentioned, today we're going to define the uncompensated care problem. And then we will review the 6 most common ways that hospitals are solving this problem. So feel free to stop us at any point with questions or to enter them in at the question bar on the right. We'll also save some time at the end. And we'll have 3 polling questions along the way, and so be sure to pay close attention.
So first, we're going to talk about the background of the Affordable Care Act and its effect on hospitals. Not having health insurance doesn't keep Americans from seeing a doctor. Millions of uninsured Americans use healthcare services every year. And since healthcare is expensive, many uninsured and underinsured patients can't pay their bills. For obvious reasons, this is a problem. It's a problem for patients who have unpaid medical bills sent to collection agencies, and it's a problem for healthcare providers who lose money when they don't get paid. In 2013, 72 million non-elderly people went without coverage for at least part of the year, and 40.8 million were uninsured for all 12 months. The cost of uncompensated care provided to those 72 million uninsured patients was $84.9 billion. Of that $84.9 billion, $53.3 billion was paid from federal and state programs like DISH payments, state indigent care programs, the Ryan White Fund, and the VA, and other programs like those. But even after these payments, hospitals were left with $31.6 billion they had to write off either to charity or bad debt. This huge problem was a major reason Congress passed the Affordable Care Act. Web-based health insurance marketplaces, for example, healthcare.gov, were designed to make it easier for Americans to find affordable coverage. The prevailing wisdom was, let's make health insurance cheaper and easier to buy, and let's watch the number of uninsured Americans drop. So how much did Tennessee spend on uncompensated care in 2013? You might be asking yourself, why should I care about this? Like, what does this mean for me? Well, in 2013, Tennessee hospitals charged self-pay patients almost $4.8 billion. And what did they collect? Only $353 million. That's only 7%. Furthermore, information from the Department of Health and Human Services indicates that 80% of patients who enroll in a qualified health plan will keep that plan for 12 months. So if hospitals could just move some of their uninsured patients into insurance plans, they could save billions of dollars. The Affordable Care Act also sought to control costs in part by trimming fat from Medicare. Since Medicare is the single biggest source of payment for many hospitals, this rightfully led to anxiety among hospital CEOs and CFOs. But when healthcare providers expressed concern about cuts in Medicare reimbursements, lawmakers responded by saying, and I'm paraphrasing here, "Don't worry, sure, Medicare revenue may drop, but this will be offset by reductions in uncompensated care. You won't have as many uninsured patients."
And it worked. Well, it worked to a point. When the Affordable Care Act's first open enrollment launched in October 2013, you can see there the uninsured rate was 17.1%. By January of 2015, that number had dropped down to 12.9%. And this 4.2% reduction represents about 13 million Americans with new health insurance. That's most and more predicted would sign up in the first 18 months. And it resulted in about a $58 billion decrease in uncompensated care from 2013 to 2014.
And it's not going away. Some of you may be wondering what the most recent King versus Burwell ruling means for Tennessee. So this case challenged the legality of premium tax credits in the 34 states that use the federal exchange. And as you've probably heard, the Supreme Court voted 6-3 in favor of the defendants in this landmark case. So the millions of people nationwide and the 156,000 Tennesseans who use subsidies to purchase health insurance on the federal exchange can now breathe a sigh of relief because they can keep their subsidies. Individuals aren't the only ones affected by this ruling. King versus Burwell has had a big impact on Tennessee hospitals and insurance companies as well. Because individuals in Tennessee are able to keep their subsidies, it's likely that they will also hold on to their health insurance policies. So when they visit a hospital for care, the hospital will get reimbursed for providing that care. Insurance companies get to keep their customers, and the hospitals and medical providers have less uncompensated care liability.
So how should we feel about this progress? Do we celebrate the fact that over 156,000 previously uninsured Tennesseans now have coverage? Do we lament the fact that over 850,000 Tennesseans are still uninsured? And should providers sit back and wait for these uninsured people to enroll? Or could they take concrete steps to help them find the coverage they need? Short answers are yes. We should definitely feel good about our progress. Yes, we should also lament the fact that over 850,000 people are still uninsured in Tennessee. And no, providers should not sit back and rest on their laurels. They are uniquely positioned to take concrete steps to help patients find coverage. So Katie, I believe it's time for our first polling question. Do you mind asking the audience?
Sure. Our first polling question is, what was the reduction in uncompensated care between 2013 and 2014? Just a reminder, to receive CPE credit today, you must be connected to the webinar for at least 90% of the duration of the webinar, as well as answer 2 of our 3 polling questions today, this being the first. And again, there is no penalty for a wrong answer. Please just go ahead and answer, and then you will be able to receive CPE credit. I'm going to wait a couple more minutes. It looks like we have about 70% who have responded. Again, there's no penalty for a wrong answer. Just please respond in order to track your participation in the webinar today. And again, you'll need to answer 2 of the 3 questions today to receive CPE credit. We have about 90% who have answered, so I'm going to go ahead and close the polling. So as far as the answers, everyone has said about 50% have said $5,800,000,000, and then about 35% have said 50 million, with the 58 billion coming in third, around 11%, regarding the reduction in uncompensated care between 2013 and 2014. John, Jim, and Lindsay, which is correct?
So the right answer is option E, 58 billion. Due to healthcare reform, we have made a lot of progress. A lot of the so-called low-hanging fruit have been enrolled. However, we still have a lot of work to do, especially with some of the more complicated enrollments. And also, people lose their health insurance every single day. So to think that we're shooting at a stationary target would be naive. We must put forth continuous effort to maintain and improve upon the progress we've already made. Okay, so who remains uninsured? So this map breaks down the number of uninsured people by county all across the U.S. The dark purple areas have the highest rates of uninsured citizens. And as we mentioned previously, it is estimated that there are still more than 40 million Americans without health insurance. So what does this mean for Tennessee? Well, in Tennessee, there are still 850,000 non-elderly uninsured residents as of 2014. This chart shows that of the 850,000, more than 600,000 are eligible for some sort of health insurance program. This could be TennCare, employer coverage, CHIP, or commercial plans. More than 1/3 of the 600,000 that are eligible for tax credits to help pay for their health insurance premiums. So this clearly illustrates that there are still a lot of people in our state that need help with health insurance.
Okay, so now that we see this as a problem, let's see how it would look if this problem were solved and all of the self-pay patients that were eligible find coverage. What would the revenue impact be for your facility if all of your eligible uninsured patients found health insurance? We thought it would be an interesting exercise for you to perform this calculation for your facility. If you have these numbers in front of you, go ahead and do a quick back of the envelope calculation. If you don't have these data points in front of you, our slides are available in the handout section in the GoToMeeting panel, and they'll also be available on the HFMA website. And you can plug your numbers into our example to get an exact calculation. So here we're using a fictitious example from a 100-bed hospital and using average number of uninsured patients that present per week, average charges for an uninsured patient, and average reimbursements from TennCare and commercial payers. The annual revenue impact of finding coverage for all eligible uninsured patients for this facility would be $1.1 million. I mean, that's a huge impact for a hospital of any size. So again, we've built a formula into our example, so if you download the slides, you can plug your numbers in and get an exact count. If you'd like more information on how we derive this formula, feel free to contact us after the webinar and we'll be happy to explain it.
Okay, so I get it. There are a lot of uninsured people still in Tennessee. You may be asking, why don't they just enroll through healthcare.gov? Why should providers have to take action? Isn't that what the healthcare.gov is for? Well, it would seem like these people could go online and just help themselves. However, the logistics of signing up are just not very simple. There are some pretty big roadblocks to enrolling. Some of the most common ones are listed here. As you can see in front of you there, they may not realize that they are eligible. People may have lack of internet access or may not be familiar with using computers. There's a general lack of health insurance knowledge. The application process is very complicated. They don't have time to wait for help over the phone. And if they do wait, many times they get an inexperienced healthcare.gov staff person who can make things very, more difficult. So sometimes people can't verify their identity online and just give up in frustration. They get confused by the number of options that are presented to them, and there's nobody there to help them choose the best option. I mean, have you seen healthcare.gov? Even if you're computer savvy, completing an application and picking a plan is easier said than done. We're going to follow a patient as he attempts to enroll so we can see just how challenging it could be.
All right, so we have compiled the steps and some of the challenges of applying for health insurance via healthcare.gov. So first, the patient goes to healthcare.gov and they create an account. At this point, they might get stuck because of a system error. If any of you out there have ever tried to apply for health insurance on healthcare.gov, this error message may look familiar. So once you get back into the system, you'll have to confirm your account, and then you'll have to verify your identity. You think this step would be easy, but you're wrong. Now you might have to call Experian to verify your identity over the phone. Sometimes this process can take a few hours of being on hold and talking with the folks at Experian. Okay, once you get past that hurdle, you have to complete your application, which includes estimating your income for the following year. Then you'll get your eligibility results to review. And this is actually a 13-page document that tells you what credits and programs you have access to, as well as what your subsidy will be. After all that, you may have to submit specific verifying documents. This could be anything from income verification to proof of citizenship or even proof of your incarceration status. And this process can actually take several weeks. Okay, wow, that was tough. So now you finally got through that and you're able to pick from one of the 106 plans available in Middle Tennessee. In this example, actually, where the patient is lucky enough to have the choices narrowed down to 40, but the patient still has a difficult choice to make. They would still have to choose one plan from a range of prices between $0 and $259, deductibles ranging between $0 and $6,600. Some plans have copays, some plans are HSA compatible, and there are many different out-of-pocket maximums to choose from. Each insurance carrier has different networks. Plans offer varying prescription benefits, and you even have to consider the reputation of the different insurance carriers, and not all are created equal. And as you can tell here, there are so many factors to consider. And if you were eligible for TennCare, this process would be even more complicated. So before we move on to our next objective, we think it's time we think about our own well-being. You know, we know how important it is to stretch each and every day. So let's take a minute to stand up and stretch. We want to make sure that you guys are staying engaged in the webinar, and we want you to get those questions right. So let's stand up and touch your toes, feel it in those hamstrings, maybe stretch the shoulders out a little bit. I know some of you guys are sitting in the computer all day with your hand out and your mouse and your keyboard. It can get stressful, so let's take a minute to stretch. All right. Doesn't everyone feel better?
Okay, hope so. Thank you, John, for that, getting our blood flowing again. That gets us to our second objective for today. We're going to talk about how more and more hospitals are choosing not to sit back and wait for uninsured patients to enroll in health insurance. Providers are getting creative about addressing the issue. So we want to give you 6 different ways that providers are thinking about this. Before we do that, Katie, we're going to go ahead and take our second polling question.
All right, and our second polling question today is, according to the Department of Health and Human Services, what percentage of patients who enroll in a qualified health plan keep that plan for 12 months? Please select one of the following: 5%, 27%, 68%, 80%, or 92%. And again, there's no penalty for a wrong answer, but you must answer at least 2 of our 3 polling questions today to receive CPE credit. We'll give a few more minutes as we have about 70% of people who have responded. And while they are responding, I will just note, Lindsay, John, and Jim, we did get one question wanting the formula or the notes regarding the formula that you mentioned to calculate. I don't believe it's in the PDF, or maybe you can point us to the slide that it is on in the PDF that's uploaded. And with that, we're at about 92% voting, so I'm going to go ahead and close the poll and also share the results with you. So it looks like about 80%, or about 39 and 32% did 68 and 80, about dead even between those 2 percentages. And then a few responding 27 and a few 92, which is the accurate answer.
Okay, the right answer is D, actually, 80%. We mentioned earlier people lose health insurance every day for a number of reasons. People forget to pay their premiums. Insurance companies can make mistakes. There can be complications with the auto draft. Sometimes folks with healthcare.gov don't communicate effectively with the insurance carriers, and people can age off of their parents' coverage. People lose coverage due to divorce, they move, etc. So actually that 80% number is fairly high given how many chances people have to lose their healthcare insurance.
Katie, and to answer the question from the audience, if whoever is interested, we have our email addresses listed at the end of the presentation. If you would like to email us, we can send you a PowerPoint version of the presentation that has that formula built in. And I'm also, or any of us are also happy to explain to you the exact formula that we use. It's a little bit complicated probably to follow as we do this. But again, we'll have our contact information at the end. So whoever's interested, feel free to reach out and we're happy to go through that with you. So now we're going to talk about the 6 ways that hospitals are addressing this uncompensated care problem. And the 6 most common ways that we've identified are to simply direct patients to healthcare.gov. Some facilities are partnering with Navigators and they're placing them on site in their hospitals. Some hospitals have trained their staff to be certified application counselors. Some partner with Medicaid verification vendors. Some facilities are referring patients to health insurance brokers in their local communities, and some are partnering with a licensed non-commissioned advisor to help their patients find new coverage. So what we've done is scored each of these 6 options in the following categories: cost to hospital, best outcome for patients, the ability to track patient enrollment and outcomes, the ability to enroll patients in qualified health plans, Medicaid, and Medicare, the burden on existing hospital staff, and then the improvement to patient experience. So we've given each option a star rating from 0 to 4 in each of these categories. We also are going to walk you through what patient experience would look like for each of these options. So let's go ahead and see how they measure up.
Okay, the first option is just to direct your patients to healthcare.gov. That's literally free for the hospital. However, for all the reasons that we mentioned earlier, it often doesn't result in the best outcome for the patients. There's also no way to really track which of your patients enroll until they return to your hospital. And while some patients obviously enroll in Medicaid and commercial plans on their own, we've seen how difficult that is. So this strategy definitely doesn't have a positive effect on patient experience. Let's see why. So you see here the patient presents in the ER. Registration staff determines that the patient is uninsured. Then the patient is treated, prepped for discharge, and as part of the discharge process, the patient is simply told just to go to healthcare.gov. They may be given some bit of information, maybe a pamphlet about the process, but no real help in applying. You can see there, so the patient probably feels a lot like this crying baby after attempting to complete an application and to pick their plan on healthcare.gov.
So the architects of the Affordable Care Act recognized that many Americans would need help in creating online accounts and navigating through these insurance marketplaces. So they actually included funding for entities that could provide this kind of assistance. And these entities are called Navigators. So some Navigator programs are funded with grant money, and others might require the hospitals to pay a fee. So while Navigators can help explain the law and counsel patients on what they qualify for, they cannot help patients apply or help them pick the right plan. Some, but not all, Navigator programs provide reporting to the hospitals. And because Navigators are limited in scope, they may have a limited impact on uncompensated care. One big plus of using Navigators is that this strategy requires little to no extra work for the hospital. And finally, having access to advice will definitely improve patient experience, but the inability to get help picking the right plan might leave patients feeling frustrated. And also, considering that there are only 22 Navigators statewide, many patients won't ever have access to them. So let's take a look at what this strategy entails for the patient. Okay, first the hospital has to obviously find and place Navigators on site. And then the patient will present themselves in the ER. The registration staff determines that the patient is uninsured. And then the patient is stabilized and prepped for discharge. As part of their discharge, the Navigator will explain how the ACA works and then show the patient the steps required to enroll in a plan through healthcare.gov. But as I mentioned earlier, the Navigator cannot help the patient pick from one of the 100+ available plans. So as you can probably guess, this baby looks a little bit frustrated. After working with a Navigator, patients in a hospital might feel the same way.
So option 3 is to train staff as certified application counselors. Many providers have asked employees to take online classes and pass an exam to become a certified application counselor. This option requires little expenditure from the hospital, while CACs can help patients submit new applications and create accounts online. They cannot legally help them choose the right plan. And because of this, it is hard for certified application counselors to track enrollments. Also, because certified application counselors are only trained to help with the federal marketplace, they can provide no help to people with questions about Medicare. Also, this strategy is going to place the largest burden on existing staff because these CACs typically have to perform this role in addition to whatever their normal duties would be. As I'm sure you know, most of your staff doesn't have an extra 8 hours a week to help people with health insurance. They're probably burning the candle at both ends as it is. Having access to certified application counselors can improve patient experience, but like Navigators, they can't help patients pick a plan. And as we discussed earlier, this can be an overwhelming task. Patients have to consider metallic tier, cost, deductibles, out-of-pocket maximums, vastly varying networks, cost sharing, and many other variables to make the right choice. So let's take a look at what this process would look like for a patient. So first, the hospital would have to have their staff trained as certified application counselors, and then a patient will present in the ER. Registration staff will determine that the patient is uninsured. The patient will be stabilized, treated, and prepped for discharge. As part of discharge, the certified application counselor will explain how the Affordable Care Act works, help the patient create an account on healthcare.gov, and show them the steps required to enroll. But like a Navigator, they cannot help them pick one of the 100+ available plans. And as you can see, this baby that we have here is clearly overwhelmed, and patients would be too. Although people would be grateful for help with the complicated application process, they'll leave feeling confused by the number of considerations in picking a plan. And they might even choose not to enroll because they're so overwhelmed by all of the options. Katie, I think that it might be time for our third and final polling question. Do you mind asking the audience?
All right. Our third and final polling question is, how many qualified health plans are available to individuals in Tennessee? 75, 106, 90, 18, or 23? Again, this is our last polling question of the day, and to receive CPE credit, you must respond to 2 of our 3 polling questions today, as well as be connected for 90% of the duration of the webinar. We have about 70% responding. I'll give a couple more minutes. Again, if you have any questions today, you can enter them into the question or the chat box, and we will hold those for our speakers till the end, or ask them as they come up. And if you have any technical difficulties, please enter those as well, and I can help you. You can also access the slides, as we mentioned in the chat box. There's a link there, as well as a link to the PDF, or email John, Lindsay, or Jim after the presentation to receive a copy of the PowerPoint. We have about 90% who have voted, so I'm going to go ahead and close the polling question. It looks like 57% have responded, 106, with small responses for the other numbers. Is 106 the accurate number?
It is, and I'm glad to see that everyone's paying attention and that we're able to drive that point home. So as we mentioned a few minutes ago, there are 106 qualified health plans available in Tennessee. That's a lot of options. Jim, I think you've got some experience helping people choose the right plan. Do you mind telling us why it's important to get it right?
Yeah, I've got some experience with this. You know, we've talked a few times today how important it is to pick the right health plan. The first three options that we discussed, they'll benefit your patients, but they don't necessarily result in the best outcome for them. So let's take a look at how important it is to enroll in the right plan and take a look at what could go wrong. We all know healthcare is changing as a result of the ACA, and more people are having to buy their health insurance, but individuals are not used to this complicated process. I found that picking a health insurance plan is more like filing taxes really than buying car insurance. So the objective of the certified application counselors and the navigators was to help individuals wade through this confusion. However, the major downside to that is that they can't legally steer people to one plan over another. So when you're faced with two plans that are before you on the screen like this, typically a person simply picks the least expensive. So we're going to take a look at these two Blue Cross plans taken from healthcare.gov. As you can see, the benefits appear to be identical. So which one would you choose? One costs $58 per month, and the other costs $84. So if you're like most Americans, you'd simply take the plan that is cheaper. But this could be a huge mistake because the plan is in the narrow E network that only includes 27 hospitals, while the plan that is only $26 more gives you access to 126 hospitals statewide. So most hospitals aren't in every insurance network, and many patients find that their preferred facility would not be in that narrow E network. So what happens if a patient meets with a navigator or CAC and chooses the wrong plan? They may come back to the hospital frustrated that because they couldn't get care at their preferred facility, or she could be subject to significant out-of-network costs. Obviously, this would be frustrating for the hospital, as this patient still would represent uncompensated care liability, and the hospital will likely even lose her as a patient.
Thanks, Jim. That was very helpful. So let's talk about our fourth way that hospitals are choosing to solve the uncompensated care problem, and that's partnering with a Medicaid vendor. Hiring a Medicaid vendor is often the most expensive of these options because their contracts are typically contingency-based. So Medicaid vendors are great at what they do, but they are severely limited in scope since they only work with patients who might be Medicaid eligible. And in states like ours that didn't expand Medicaid, we all know that this is a pretty small portion of the population, typically, anywhere from 16 to 19%. Medicaid vendors do a good job of tracking enrollments because they need to do that to get paid by the hospital. And as with hiring any third-party vendor, this strategy would cause little burden on your existing staff members, so they'd probably be happy about that. This strategy will have a positive impact on those patients who are eligible for Medicaid, but it will leave the rest feeling pretty discouraged. So let's see what patient experience looks like if you partner with a Medicaid vendor. So first, a provider would hire a Medicaid vendor to work on site in their hospital. Then when your patient presents in the ER and they're determined to be uninsured, registration will probably screen them for Medicaid eligibility. Then obviously they'll be stabilized, treated, and prepped for discharge. So if they were screened and determined potentially eligible, the patient might sit down with the Medicaid vendor and apply, typically via healthcare.gov. And normally this is where help from a Medicaid vendor will end. They will, like we've already said, share reporting with the hospital, so that way the facility can update their billing system and go ahead and submit claims for those newly enrolled patients. But because we live in a state that did not expand our Medicaid program, implementing this strategy will leave people who don't qualify for TennCare feeling just as confused and frustrated as they did when they walked in the door, which is kind of how this baby looks on this slide.
Lindsay, have you helped anyone apply for TennCare?
Yeah, Jim, I have actually lots of times. And as it turns out, submitting the application online is just the tip of the iceberg. Tennessee does not have a Medicaid verification system that integrates with the federal marketplace. And this means that sometimes it can be a nightmare to actually get someone enrolled in TennCare. Even if they clearly qualify, there's so much follow-up and verification between entities that don't communicate with one another that patients often give up in frustration. I've seen one application for a single mother who clearly qualifies for TennCare take 8 months to be approved and have her get enrolled in an MCO. So typically, Medicaid vendors are paid per enrollment, so they are not incentivized to help people with this complicated follow-up process. Also, you have to re-enroll in TennCare annually, and since this wouldn't represent a new enrollment for a Medicaid vendor, they might be less likely to help these patients with their re-enrollment.
Wow, thank you, Lindsay. I did not know how complicated the TennCare application process was. So let's go to option 5. Some hospitals choose to refer patients to health insurance brokers in the community. While this strategy represents no cost to the hospital whatsoever, patients may not get the best outcome because they are working with a commissioned salesperson. And because they're commissioned, brokers may be incentivized to steer people toward a plan that pays a higher commission, or maybe even toward an insurance company that pays a higher percentage. That being said, brokers are able to help people submit healthcare.gov applications, pick plans on the exchange, and even navigate Medicare options. Since these brokers are not affiliated with the hospital, they would most likely provide no enrollment tracking information. For the same reason, brokers place no added burden on hospital staff. So this strategy does little to improve patient experience because the patient still has to seek out a reputable broker in the community. Let's take a look at what this process looks like through the patient's eyes. Okay, so the patient will present themselves in the ER. The registration staff will determine that the patient is uninsured. Then the patient is stabilized and prepped for discharge. As part of the discharge, the patient is given the business card of a broker in town and are told to call in for help. They may or may not call. Also, the commissioned broker may try to sell the patient a policy that is not right for their needs. Okay, so this baby here has his hands on his head for a few reasons. First, he may feel a little bit frustrated that he's being sent outside the hospital for help with health insurance. Second, the broker may try to sell him other products such as car insurance or life insurance. And finally, the patient may find that he wasn't put on the right plan because the broker was incentivized to steer him in a different direction.
Okay, that brings us to option 6, and that's to partner with a licensed non-commissioned advisor. Putting a licensed non-commissioned advisor will most likely require a modest investment for the hospital. That said, it may result in the best outcome for the patients and the hospital because these advisors are able to give advice on all Medicaid, Medicare, commercial health plans, etc. Generally, these advisors track their enrollments for the hospital. And as we mentioned earlier, hiring outside vendors places really little or no burden on existing staff. Because non-commissioned advisors are incentivized to help each type of patient find the right plan, this option is going to greatly enhance the patient experience. So we see here that the provider will place a licensed non-commissioned advisor on site in the ER. When the patient presents in the ER, he's stabilized, treated, and prepped for discharge. As he's being discharged, the advisor will meet with the patient to identify the best coverage option, be it Medicaid, Medicare, or a commercial plan, and will enroll the patient in new health insurance. Then the vendor will share a report with the hospital so they can update their billing system and submit the claims for the new enrolled patients. You can see there the baby's face says it all. This strategy is going to result in the best outcome for the largest number of your patients. That should also translate to the greatest increase in revenue for the facility.
Jim, I have a question for you. So these last two strategies offer assistance applying for Medicare. Why are these the only two options that have this benefit?
That's because we're using agents and non-commissioned advisors in the last two options that we discussed. They actually have their health insurance license. And you have to be licensed to give advice about Medicare.
Oh, okay. That's interesting. Well, how complicated is Medicare? I thought I was automatically enrolled when I turned 65.
That's a good question, Lindsay. It turns out there are 28 ways you can receive your Medicare benefits, and all options aren't equal. If you're drawing Social Security, you automatically are enrolled in Parts A and B. Otherwise, you have to apply via Medicare.gov. For most people, A and B are not enough coverage, so you need to determine which of these 28 strategies is your best fit, and I can tell you, you will want help in that experience.
Oh, okay. Well, that sounds way more complicated than I thought, but why is it important for the facility that the patient get the right Medicare coverage?
Well, usually getting it right can save the patients thousands of dollars on their health care costs. We find that what's best for patients are often what's best for the providers and can lead to better reimbursements for the provider.
Interesting. Okay, if there are any providers represented today, this chart here could help you pick the best strategy for your facility. We wanted to show a side-by-side comparison of each category because we realize that some of these categories will be more or less important depending on your specific circumstances. So the next several months represent a unique opportunity to accelerate the rate at which patients get connected with health insurance coverage. Providers are positioned better than any other stakeholder to help chip away at the uninsured and underinsured rates. And providers are also positioned to benefit the most from reductions in uncompensated care. So the providers that take advantage of this opportunity will more effectively deliver on their mission. They'll also help solve the uninsured and uncompensated care problem for your community. Katie, were there any questions that were submitted?
Right now, we do not have any questions that have been submitted that have been unanswered. Certainly, any of our attendees are welcome to submit a question into the question box or into the chat box if you have any questions that for our presenters today. As you can see, they have posted their email addresses, and that's also in the handout that you can access via the link below in the chat box or by downloading the PDF in the handout section. And you can follow up with them if you have any additional questions or follow up about that formula they mentioned they'd be willing to share. Since there are no additional questions, we'll go ahead and close today's webinar. And thank you very much to Lindsay, John, and Jim from Bernard for presenting on the topic of uncompensated care. Thank you all for attending, and we look forward to having you at our next Tennessee HFMA webinar, which is on valuation and physician productivity. Thanks so much.
Great. Thank you, guys.
Thank you.